thank you again to the organizers for the opportunity. Thanks for the applause. And then, so I'm Colin McCrimmon. I'm one of the Epilepsy Fellows at the West Los Angeles VA, as well as the UCLA Medical Centers. And today, we'll be talking about epilepsy after traumatic brain injury. So pretty informal talk, so please just jump in, raise your hand if you have any questions. So just briefly, I'll kind of define what a TBI is, a traumatic brain injury, kind of what are the causes of TBIs, and then seizures after TBIs, including post-traumatic epilepsy. And then what are the treatment options in terms of medications, surgical options, and kind of future directions. So just some historical context. So epilepsy after TBI counts for about 5% of all epilepsies, so a pretty large portion, and people have known about epilepsy after TBI for about 4,000 years. So epilepsy is not new. Back in ancient Egyptian times, they had actually detailed 5 separate accounts of epileptic seizures, and so they called this basically patients who shuddered exceedingly as a result of injury to the head. For one patient, there was a gaping head wound, and this was kind of documented in the Edwin Smith papyrus that we have from 1700 BC. Another famous case, so Harriet Tubman was known to have developed epileptic seizures as a teenager after she was struck in her head. And then another kind of famous medical case was Phineas Gage, who was a railroad construction worker. He had a tamping iron driven through his skull, and that resulted in post-traumatic epilepsy, as well as personality changes, as one might expect. So what is a traumatic brain injury, a TBI? So the definition is just any injury to the brain caused by an outside force, like a bump, a jolt, blow to the head, that causes symptoms. So TBIs and concussions kind of used exchangeably. TBIs are just a little more general term. And so about 1 in 5 adults have had a TBI severe enough to cause loss of consciousness during their lifetime. So it's like, 1 in 5 of us. So very high number. And then TBIs account for about 2 million hospital visits annually. So one of the things we talk about, especially in the context of epilepsy, is TBI severity. And so most TBIs we count as mild, and that's about 90%. And when we say mild, this includes most concussions. It really just means that there's no evidence of injury when we look at the images like CAT scan or MRI. The brain doesn't show any kind of abnormalities on that imaging. And then the kind of altered consciousness that the patient experiences is very brief. So we usually say less than 30 minutes that they lost consciousness, and then they're usually alert and following commands kind of when they're first evaluated. So on the opposite end of the spectrum, moderate and severe, so these are much rarer, but there can be evidence of injury on the MRI or CT scan, longer periods where there's altered consciousness. They're either confused for a long period of time, they've lost consciousness completely for a long period of time, and when they're first evaluated in the emergency department, they're not following commands. They have a very kind of high coma score. In our Glasgow Coma Scale, it's kind of the opposite. It's very low score, so 15 is normal, and these are patients who have 9 or less, so not able to function kind of at a regular level. And TBIs are a clinical diagnosis. What are the causes of TBIs? So when I think about TBIs, I usually think about motor vehicle accidents. That's very common, but actually falls are more common. So about 35% of TBIs are from falls. So mainly in the in basically the 0 to 14-year-old population, as well as adults 65 or older. Motor vehicle accidents only make up about 17% of TBIs, and then the other common one that we think about is like sports injuries. Those are only about 17 as well. In our veteran population, so there's actually a high risk of post-traumatic epilepsy due to penetrating injuries, especially in the Korean and Vietnam Wars, and then basically IED blast injuries as well in some of the more recent operations. And lastly, kind of what areas of the brain do TBIs affect? So every injury is unique. It's really just the mechanism of injury that matters. But when you think about a lot of the falls, a lot of the collisions, it's usually the front of the head getting hit. And so that's why in this figure that you see over the right side, a lot of that I'm highlighting the color is kind of the frontal areas. You're kind of looking at the brain front on. And those are areas that are important for kind of working memory, executive functions, a lot of attention, kind of judgment, emotion, as well as some like fear responses. And and kind of in the back, sometimes you can get some problems with coordination. So, as well as arousal. So some patients after TBI, they'll have changes in their mood, changes in their kind of their memory, changes in their cognition. They may be really sleepy. That's kind of when the arousal pathways are involved, and then they may have a lot of problems with walking, a lot of instability. And it really, the areas that are involved in the TBI are what is involved in post-traumatic epilepsy as well. So once it develops. And overall, just any type of prior TBI is associated with a substantial risk of developing epilepsy, I should say. And there's a few studies that kind of showed this, especially in our veteran population. So let's talk about seizures after traumatic brain injury. So the classification of seizures, we kind of break it down into, was it an early seizure or was it a late? There's something that I briefly bring up here called immediate seizure, and it's pretty controversial. It's if you suddenly had a sports injury, suddenly had a concussion, some patients may have some convulsions, and those aren't necessarily epileptic seizures, but they're kind of part of the concussion itself. So we have a lot of those from the sports literature, but the real thing that we think about when we think of kind of the epileptic seizures are early post-traumatic seizures. So this occurs within 1 week of the head trauma. It occurs in about 5% of all TBIs, especially severe TBIs, and usually they'll occur within the first day. About 25% are within the first hour. And they're typically what we think of as kind of the grand mal, the big generalized tonic-clonic shaking episodes. But later on, if they happen like a few days after the initial injury, they can have more focal findings, so they can look more like a focal impaired seizure, or what we used to call complex partial seizures. They luckily only carry us, even though they're very common, they carry only a small risk of developing post-traumatic epilepsy. And we usually don't recommend anti-seizure medications for these seizures unless they get really common, like patients are having them very frequently during this acute phase, because they don't protect against developing post-traumatic epilepsy. So early seizures within a week, it's kind of just a sequelae of the injury itself, but it doesn't mean that you're going to have post-traumatic epilepsy afterwards. And so, if they're really frequent during the first week, we'll give them the medications just for that. But otherwise, again, it doesn't kind of help long term. And there's some evidence in the rehab world that anti-seizure medications in general, kind of in this early phase, can also hurt rehabilitation outcomes, so recovery outcomes. And some common studied seizure medications, levetiracetam, Keppra, or phenytoin, Dilantin, those are kind of used. They're good for these early post-traumatic seizures, but there has been some literature that said that valproic acid, which is another commonly used one, it's effective, but it has been shown to be associated with an increase in mortality, so we say avoid that one. So we talked about early seizures. Now let's talk about late post-traumatic seizures. So these occur after 1 week from the head trauma. And these are reflective of more kind of permanent changes in the brain. So whether the brain network gets disrupted or there's scar formation. And these changes are what actually predispose patients to have post-traumatic epilepsy. So they're more likely after TBIs that are severe. So about 10% is the 10% of patients who have a severe TBI will have basically a late post-traumatic seizure within a 5-year span. And then much less, though, for moderate or mild. So just, again, higher risk with more kind of severe injury. And that includes kind of skull fractures, associated bleeding in the brain with the injury, older age, and possibly genetics as well, which we'll touch briefly on. So this shows just kind of patients with kind of a meta-analysis, patients with late seizures, about 10% would develop them at month 60, which is 5 years. And you see that kind of the lower bars here, I don't know if you see my mouse, but right at the bottom, at 5 years, there's some that are like 1.2%, 0.7. Those are because those are milder patients. So severity does matter for the injury. And what is post-traumatic epilepsy then? So I think you might have heard it before. Epilepsy we generally think of as 2 seizures that are unprovoked and that are at least 24 hours apart, or 1 seizure that's unprovoked and there's a high risk of having subsequent seizures. So that's kind of our working definition of epilepsy to begin with. Post-traumatic epilepsy is no different. It's just basically 2 unprovoked late post-traumatic seizures, or 1 unprovoked late post-traumatic seizure and a really high risk, over 60%, of a subsequent seizure in 10 years. Well, patients who have 1 late post-traumatic seizure actually have a very, very high risk of going on to have a subsequent one. So about 82% of moderate severe TBIs will have a recurrent one. So they already meet criteria for post-traumatic epilepsy. So basically, 1 late post-traumatic seizure after a moderate or severe TBI, and you already have traumatic epilepsy. So what are the risk factors? What makes some people more likely to develop post-traumatic epilepsy? Well, again, we talked about the TBI severity, older age, the presence of early seizures, even though it's kind of weak, they still are an increased risk of post-traumatic epilepsy. And again, kind of more severe injury with skull fractures, bleeding in the brain, kind of abnormal EEGs or neurological exam. And again, maybe some genetics. There's a few genes that people are studying right now that may predispose patients to have post-traumatic epilepsy. One of those, the first one here, ApoE4, this is actually, you might have heard of it before in terms of Alzheimer's disease and kind of other neurodegenerative diseases and dementias, but it's also important as a possible risk factor for developing post-traumatic epilepsy after an injury. It's still kind of unclear if family history of epilepsy plays a role. A few studies have shown that it does. Kind of a large Vietnam injury study showed that it didn't. So we're still kind of unclear. But the overall idea is this 2-hit hypothesis that some patients just have a maybe genetic predisposition, a susceptibility, and that's kind of the first hit. And then you have this injury, this TBI, as your second hit, and this is what actually produces the epilepsy at that point. It's kind of a theoretical framework, but maybe it just represents like the repair mechanisms of the brain aren't acting as they should from the genetic disposition. So one thing that we think about is what is the time course of post-traumatic epilepsy developing? It actually develops pretty quickly. We say within 5 years, 85% of patients have developed post-traumatic epilepsy, and so it's pretty unlikely that if you go 5 years without a late post-traumatic seizure, that you're going to develop post-traumatic epilepsy. There are a few cases, it is possible, there are a few cases where it does happen. There's one case that went up to 35 years after their injury, but most of the time it's within 5 years. So if you don't develop it, it's much less likely that you will in the future. And generally about half of patients will develop post-traumatic epilepsy within the first year of their injury. So the big question is, what are the recommendations for starting treatment? So before your first late post-traumatic seizure, there's no reason to start medications, and that's kind of what we use right now. There's side effects of medications, kind of cognitive and behavioral, and like we talked about with traumatic brain injury in general, those are already going to be an issue, and they could even interfere with recovery. And again, it doesn't prevent the development of the epilepsy itself. After a mild traumatic brain injury, and a single late post-traumatic seizure, there's really no strict recommendation for starting medication because they haven't kind of like again with a mild TBI, there's not as high risk of this post-traumatic epilepsy, and this is where we kind of use CT, MRI, we do an EEG, we kind of look at a neurological exam, we see if there's anything that says, this looks concerning, we should start the medication for this patient, but this patient has a pretty normal exam or normal imaging findings, let's hold off for right now. So there's no real strict recommendations for that, but if they do have a moderate or severe TBI, that's when, and they have this single late post-traumatic seizure, again, like we said, they kind of already meet the diagnosis for post-traumatic epilepsy, so we should absolutely start a medication at that point. We'll talk a little bit about the medications in just a few slides. And then again, don't treat the early ones, don't treat the ones before 1 week. And if you do, it's really just preventing the seizures in that 1 week period. So you can do a short course, and you'll see that sometimes about 1 to 2 weeks on like seizure medication like Keppra, and then off. We have a lot of seizure medications now. There's not many that have kind of undergone head-to-head comparisons, and so there's no single seizure medication that's best for post-traumatic epilepsy. And again, there hasn't been really comparisons between them. We have the ones that have been studied the most have been Keppra, levetiracetam, dilantin, phenytoin, and then valproic acid. And so those are kind of the best studies after post-traumatic epilepsy. But there's a thought that if in doubt, go with the Keppra. It has some additional benefits in terms of kind of neuroprotection, cognition. Phenytoin, we know has a lot of other kind of unfavorable side effects as well as some cognitive effects. And valproic acid in one kind of small trial, it was associated with higher mortality after basically a TBI. So we kind of avoid that one. But again, with the chart on the right, there's 20 to 30 medications that we haven't studied. So there's a lot of options, and we're just kind of extrapolating between them. So what happens when medication isn't an option? So basically for post-traumatic epilepsy that doesn't respond to multiple seizure medications, we're kind of in the realm of surgery. And in one study on epilepsy surgery, there was similar outcomes between post-traumatic epilepsy and non-traumatic epilepsies, specifically for mesial temporal lobe epilepsy. So that's a very common type of epilepsy in the general population as well as the post-traumatic population, and surgery seemed to be kind of equivalent in both. So that's good. We can kind of go with the same approach. And so patients after post-traumatic epilepsy, they still need the typical kind of pre-surgical epilepsy workup. So we think about coming into the hospital, doing the epilepsy monitoring unit stay where they're hooked up on the EEG for a week at a time or 2 weeks. And then after that, we may even think about kind of invasive monitoring. So they come back to the hospital and we put in the depth electrodes to listen even with finer detail to the signals in the brain to figure out where the epilepsy is coming from. So what happens if surgery isn't an option? And this is the case when, let's say the area that we know the seizures are coming from is over a really important area in the brain. So whether it's coming from like a language area, we don't want to mess with that area. If it's coming from an area where that controls kind of our movement, that's something that we would never kind of go in for and actually remove. So the other possibilities are what we call neuromodulation. There's kind of 3 devices available now for epilepsy care. There's very limited kind of trial data in the realm of post-traumatic epilepsy with these neuromodulation devices. But the FDA, they're still kind of under the guise of the FDA's approval. So we can still use them, but we just don't have that much information about them. So the first one is the vagus nerve stimulator, and that's kind of the best studied. So there was a cohort of, I think, 57 patients that looked at kind of post-traumatic epilepsy responses with VNS to non-traumatic epilepsies, and it actually showed that the post-traumatic epilepsy patients responded slightly better. It was about equivalent or slightly better. So it was 76 versus 61% after 2 years. So at least there was equivalence there. And then in a smaller study for specifically 7 post-traumatic epilepsy patients, the average seizure reduction was with the VNS was about 30%. So there's some benefits. We have one minimal trial that kind of compares post-traumatic epilepsy versus non-traumatic epilepsies, and they seemed at least equivalent, if not slightly better, in favor of the post-traumatic epilepsy for VNS. But that's pretty much what we're working with. There have been no studies for deep brain stimulator. That's a device that basically goes deep into the kind of inner part of the brain, both sides, and it just provides kind of the stimulation chronically. And we've seen kind of benefits for this. It's used a lot in movement disorders. There's a newer device called the responsive neurostimulator, and it's kind of like a closed feedback loop. So it's actually sensing when a seizure is starting or signs of a seizure, and then it'll kind of deliver stimulation to kind of suppress it. Kind of like a defibrillator in the heart, but for the brain for seizures. And we only have basically a study of 3 patients. It was actually the same patients of that 7 patient trial for the VNS. 3 of the patients who failed the VNS got RNS afterwards. Again, these were post-traumatic epilepsy patients. They didn't actually have a significant improvement in reducing their seizures with the RNS, but it did reduce their seizure severity. So what about future possibilities? So I'll talk about the sea lion, why that's on in a second. But there's other types of medications that are kind of being studied right now that are not seizure medications. And the goal is that these act on cells after injury, especially if we give them early enough, and they may prevent kind of irreversible changes that contribute to the post-traumatic epilepsy. So if we're able to get there in a few days, and that's kind of what animal models have shown, and kind of help with these repair pathways, patients might not develop post-traumatic epilepsy. One of these that's been studied is something called rapamycin. We use it for basically other types of diseases, but it kind of affects this large cell pathway called mTOR, but it has prevented post-traumatic epilepsy when given in rats from developing. The other types of therapies that are potential future directions as well, they're cell-based therapies, so some stem cell-based therapies have been already used in animals. They've shown promise. They've actually entered into human clinical trials right now. So the jury is still out in terms of epilepsy in general, and specifically, we don't know how this will play into post-traumatic epilepsy results. So one example, kind of in this line, there was actually back in 2020, there's a California sea lion called Cronut who had epilepsy. It wasn't post-traumatic. Basically, sea lions and marine life can have epilepsy induced by toxins from algae blooms. And so this happened for him, and it was kind of intractable. Some veterinarians had kind of given him many seizure medications, and he had failed that. And so they ended up working with UCSF, and they had transplanted pig embryonic kind of brain tissue, and this is specifically a type of cell that usually kind of suppresses other brain cells. And they used that, they transplanted it, and he'd been seizure-free for multiple years. So things to look forward in the future. Again, this is very early. Only the stem cells are just entering human trials, and we don't know. And again, this was a case of non-epilepsy, of non-traumatic epilepsy. But just to summarize, so TBIs are very common, and they do increase your risk of developing epilepsy. And timing of those seizures matters after TBI. So again, in the acute phase, in that 1 week phase, there's only a small risk that you'll go on to develop post-traumatic epilepsy. And so we don't need the treatment. Treatment has side effects potentially. And then, but after a week, that's when we start entering the realm of a very high risk of subsequent seizures and post-traumatic epilepsy. So if you have it after a week, you'll likely require kind of seizure treatment ongoing. Severity of TBI matters, like we talked about. More severe TBIs means more likely that you'll develop post-traumatic epilepsy. And then genes may play a role in susceptibility in some patients, but this is an active area that we're studying. And it's unlikely that you'll develop post-traumatic epilepsy if you haven't had any late post-traumatic seizures for about 5 years. Again, so you're kind of out of the clear after about 5 years. It's only about 15% of patients who will, and that number continues to drop off pretty precipitously. It can still happen, though. Like we said, no one seizure medication is best for post-traumatic epilepsy. When in doubt, you usually have gone with levetiracetam, Keppra, just because the few trials that looked at that included Keppra and had the most benefit with the least side effect profile. But there are other newer ones. There's clopidogrel, Briviact, other ones that were never included in the original trials. We only tried 4, and you saw that list of about 30 medications that we have now. So, and lastly, surgery and neuromodulation are still options when medications fail, but we do need more studies basically to tailor these and the decisions to patients with post-traumatic epilepsy. We kind of know how they work for the general population with epilepsy, but not specifically post-traumatic epilepsy. So with that, I'll take any questions. Okay. I know it's a lot of information, so please, any questions, comments? Oh, thank you. Thank you. I have you mean like a email or something? Yeah, email. Yeah, I have that available. Oh, okay. Yeah, I'm happy to give my email. That's it's just through our university, yeah. I don't have it listed, but yeah, I have a card. Yeah, so it's something that's still in summary, they're an active field that we've barely touched on when it comes to kind of surgical options, medications, and so, as we're learning more about post-traumatic epilepsy, I think we'll have better solutions, but it's still kind of ongoing. Yeah. Specifically with if the TBI itself was more or less moderate or severe, then pretty much you're in that 82%. So you basically have epilepsy at that point. Exactly. Yeah. The only time after kind of that, after that 1 week, if you have a seizure, the only time where there's a little bit of wiggle room is if it was only a mild TBI, and then you'll be talking with your doctor about whether you should, whether you want to start a medication, whether you want to see if there's a second one. If there's a second one, then you have epilepsy as well. But if it was mild, you can kind of think about that. If it's moderate or severe, you already have it by definition, so you should start it. So it's a clinical differentiation, but it's based off of basically when a patient has a TBI, they come into the hospital. The first evaluation, we look at, there's a coma score. It goes between 1 to 15 or 3 to 15, and basically you have to be kind of high functioning. So between 15 is normal. 13 to 15, that puts you in the low, kind of the mild category. You also have to have a very brief lapse of consciousness, so only 30 minutes. If it's more than that, you already kind of fall into the moderate or severe. So when you think of concussions, like sports injuries, things like that, a lot of them are very brief, and that's why they usually fall into the mild. But if they're out for a long period of time, if they're really confused afterwards and it goes over 24 hours, things like that again will kind of push you into the more moderate category. So, but yeah, that differentiation is really important when it comes to kind of that late post-traumatic seizure and when you want to start medication. So, of course, yeah. Yeah, so if we want to treat in kind of the early, basically a patient has a traumatic brain injury, and the question was basically, should we, if you want to treat prophylactically just to kind of prevent seizures in that early phase, that's completely acceptable, and we do it all the time, especially for kind of severe injuries that we're worried about. And it's more to prevent seizures in that early 1 week phase, as well as if there's any comorbidities, if the patient was on a lot of, kind of on a ventilator, on a lot of other devices, and maybe they were getting surgeries, and having a seizure during that time would be really detrimental to their other care, then we'd say definitely put them on a seizure medication. But it's usually we try to take those off by about 1 or 2 weeks, because just being on that seizure medication is not going to help them in the long run. But it's reasonable to do. There's no evidence against it, and it's really kind of a case-by-case decision. So, yeah. And especially some patients will have what we call status epilepticus, where they won't have they have a seizure that doesn't terminate on its own. So they require medications just to stop the seizure. And in that case, we start medications as well during that early phase just to prevent any of those recurrent seizures. Right. We do see with veterans, sometimes there's not a clear single event, but it can be many different just head injuries, they're out in the field and they hit their head and they remember this happening a few times, or sometimes boxers, they'll have their bell rung a few times. It's not a single injury that, is the precipitating factor, but maybe over time. We don't know about the kind of the time course for those seizures even as much as just a single event. So I think that there's still a lot of research to be doing, because the timing, the onset might be much later. Maybe it's not kind of a 5-year, you're okay after, after 5 years. It might be even longer because it's kind of a buildup. It's more of a chronic problem. process, but we're not sure yet. So, of course. Yeah. So, thank you so much. Yeah, have a great rest of your day. Thank you.